patients.
Thank you very much, Anna. Megan's so good that she nearly had me convinced. But no, I can't be convinced because I have to present this. I can't just take defeat and just walk out the door. I've got to fight my way through this. Oh, I can only get this thing working. So, disclosures, I have none to present. My part of this topic is to say that we should not be performing regional anesthesia in patients who are asleep. I know Megan's nicer, she's louder, but she is, and she's very convincing. But I'm going to be the same as Meg can be and try to convince you that you shouldn't be doing regional anesthesia in patients who are asleep. So, this is the debate, right? Should ultrasound-guided regional anesthesia be done in patients who are asleep? And I say, no, it should not be. So the first thing I'm going to say is that my first thing is that patients, this paper by Oroy, which was presented as a prospective survey in France, and it kind of looked at about 4,927 anesthesiologists in a 5-month study period. However, only 14.9% actually responded, which is a pretty low response rate, but they had a large number of anesthetics. They had regional anesthetics that was like 100,000, more than that. And they had about 21,000 peripheral nerve blocks. And basically what they found was that in all these cases, basically of epidurals and peripheral nerve blocks, that the needle placement was associated with either paresthesia or pain on injection when the block was performed. So I think that these are this is a kind of a recurring theme that will be in my talk, which will be the paresthesia and the pain that patients feel on the insertion of the needle. And is that related to nerve injury? Going back to Benamoff's paper, I know it's been talked about a lot in these sessions. He reports 4 cases from the closed CAME database in which he shows interscaling blocks under general anesthesia did cause total spinal anesthesia and severe cervical neuropathy, cervical cord injury. And as Meg told you, the GH is considered to be a relative contraindication to an interscaling block. And that was a take-home message from his paper. And it kind of did move the regional anesthesia world around and said, okay, we should be looking at paresthesia and we should not be doing regional anesthesia on patients who are asleep. Then, as we know, the ISURA advisory guidelines came out on neurological complications, regional anesthesia, and pain medicine in 2008. And they said that, a big circle at the bottom in their graph, which I'm going to highlight to you, saying that because general anesthesia or heavy sedation removes all opportunity of patients to communicate symptoms of potential nerve injury, peripheral nerve blockade should not be routinely performed in most adults under general anesthesia and heavy sedation. Coming back to Meg's case report, they do say that it can be used in certain conditions where patients have dementia, developmental delay, or in which intended movement can compromise their vital structures, for example, in pediatrics, as Ruth has told us. Now we come to new technology. So does it change things? It's sometimes hard to keep up with new technology. The peripheral nerve stimulator came out first, never really showed any advantages over the paresthesia because of the number of sizes, the number of study patients that were required to show any difference, and now we have ultrasound. Will that show a difference? Does ultrasound make us more confident? We can see the nerves very clearly, we can see the arteries, we can see the vessels, we can see the muscles, we can see everything very clearly. But do we want to be able to visualize these things, but on the other hand, take away the patient's symptoms or the patient reporting back to you or the patient as your monitor away from us? So, can it reduce nerve injury? Can it reduce LAST or local anesthetic systemic toxicity? And should we allow people to perform regional anesthesia under general anesthesia? That's not my decision, but this is something that we have to think about when we are doing regional anesthesia. Let's talk about nerve injury. So this is a great editorial that came out in 2007 by Teresa Holliker and Denise Riddle. Basically, they decided that we're looking for the holy grail of regional anesthesia, something that's going to take away all complications, take away all problems that we having at the present moment regional anesthesia? And will this ultrasound machine be the thing that's going to be the one holy grail that's going to take away all complications of anesthesia? So the question is ultrasound the holy grail of regional anesthesia? Coming back to Beagle license talk again, looking at it from a different perspective, okay, he had no nerve injuries in his 26 patients, small sample size. But on the other hand, of the 72 nerves that he did actually puncture and he did inject intraneurally, 66 of those patients complained of 66 nerves being punctured and injected in. Patients complained of paresthesia and dysesthesia. So therefore, this is, I think, a very important symptom that patients do report prior to neurological injury. Now, if the sample was bigger, maybe it would be a different story altogether. Going back to Fredrickson's paper, again, Meg has referred to this paper, but let's looking at it from a different perspective. The block was done under GA, we know the numbers there, but if you look at the fact that in these 1,000 patients that were done under ultrasound-guided peripheral nerve blockade, paresthesia during procedure was clinically significant. Patients who had neurological injury did complain of paresthesia prior to prior to injection or when the needle came in contact with the nerve. And that's, I think, very important. This is a large sample size, and in this case, this relationship between paresthesia and nerve injury was pretty significant. Abraham's paper, again, he looked at 13 studies in which he looked at 946 patients. He said that ultrasound comparing to nerve stimulation was actually a better block to do. It was actually had some advantages. It had a faster onset. It had a longer duration of action. There was less risk of vascular puncture. But on the other hand, in his conclusion, he says that the larger studies are still required in which we can say that ultrasound can decrease the number of complications such as nerve injury as well as systemic local anesthetic toxicity. So those two things are still in the gray area. Looking at Barrington's paper again, we're coming back to a lot of the same papers that have been published again being presented. He looked at 7,000 patients. Okay, he had very few patients with complications, but he had found no reduction of incidence of nerve injury with ultrasound and with nerve stimulation. And this is probably one of the biggest surveys ever done, which looked at ultrasound and nerve stimulation. So let's look at local anesthetic toxicity. So only a few case reports out there. Maybe the biggest prospective study is Barrington's paper again, which we'll refer to later on. But looking at this, the two case reports that were published in 2008, which showed a patient having axillary brachial plexus block, 50 mils of local anesthetic deposited on the medial side, visualized, and then on the lateral side, 10 mils were injected, but only 5, at the end, the 5 mils that were injected were not visualized. In this case, the patient became agitated and lost consciousness. So therefore, even though you can actually see the local anesthetic being spread, and you can see the local anesthetic spread and visualize it, may not actually prevent local anesthetic toxicity. Second case report published in the same journal, same anesthesiology journal edition, basically. Looked at, again, ultrasound and peripheral nerve stimulation to perform axillary brachial plexus blocks. In this case, they injected about 3 to 4 mils only in each nerve. However, they visualized local anesthetic spread all the way through. And there were no signs of bleeding in the axilla, but the patient developed a generalized seizure and became agitated and developed a generalized seizure. An editorial in the same edition of the journal came out, in the same issue, the same issue of the journal came out, and basically by Amir Hazik, Salah Blanche, and Zhu, saying that ultrasound guidance without a doubt is one of the most significant developments in regional anesthesia. But it could be collectively a judgment. It could be a collective judgment error to lean on this technology as a replacement for all existing practice strategies or as a panacea for all safety considerations. Barrington's paper showed that there were 8 cases of local anesthetic toxicity, out of which 4 were with ultrasound and peripheral nerve stimulation. So therefore, again, we cannot say that ultrasound completely takes away the symptoms of local anesthetic toxicity. In conclusion, I would just like to say that bring you to the paper that was published by Joseph Neal in 2010, in which he was doing an evidence-based analysis and looked at he looked at 22 studies which were comparing of nerve injury, 17 studies which looked at local anesthetic toxicity, and about 3 or 4 studies in which he looked at hemidiaphragmatic paresis. And in that paper, as a conclusion, they say that ultrasound-guided regional anesthesia seems to be associated with perioperative nerve injury at an incidence similar to historical reports of nerve injury with peripheral nerve stimulator. So therefore, if you were not doing peripheral nerve stimulation techniques on asleep patients, then you shouldn't be really doing ultrasound-guided blocks on asleep patients. And the weight of conflicting evidence is that ultrasound-guided regional anesthesia does not affect the incidence of local anesthetic toxicity. So that incidence still remains the same. This is a paper that's been published in 2010. However, I'm not familiar with the paper that was published by Brian Seitz that Meg referred to, so that may have a difference. So, ultrasound guidance, probably ultrasound is not the holy grail of regional anesthesia. So we still are in search of the holy grail. We can't be victims of new technology. We don't want to be victims of the new ultrasound technology, make it look cool, make it look good. And therefore, we should stick to more traditional methods. We should take away our undying urge to put all our patients to sleep and then do our blocks on it, although we are anaesthetists and it comes as a natural urge to us to put everybody to sleep. But we should then fight that. So we should keep our patients awake and not asleep. So that's all. Thank you very much.